Healthcare stands at a crossroads. Technology is advancing exponentially, but organizations are struggling to keep pace. The future belongs to those who can thread the needle between innovation and transformation. This is the Eye of the Needle podcast with Pam Arlotto.
Welcome back to the Eye of the Needle podcast. I'm your host, Pam Arlotto. Today, I want to talk about something that every healthcare executive, every physician leader, every CFO and CIO, every nurse leader, and frankly, every consultant has talked about for decades: silos. We've heard it all and talked about it. We need to break down the silos. We're too fragmented. We need more coordination and collaboration. We need everyone rowing in the same direction. Becomes one of those phrases that gets repeated so often that we've almost stopped asking what it actually means. But today I want to challenge a different assumption. I don't think healthcare has a silo problem. I think healthcare has an operating model problem. We talked about it in the last episode, and I want to dig a little bit deeper. Silos are the symptom of an operating model that was brilliantly designed for a very different time and place. The most dangerous place in a health system is not inside a silo or the organization charts that support it. It's between them. The white spaces across that organization chart, across different entities, and throughout different segments of the health and healthcare industry, the handoffs, the transitions, the interfaces, the places owned by no one, measured by no one, and funded by no one, and unfortunately, the places where patients fall through the cracks. Let's begin with something that may surprise you. I don't think silos were a mistake. In fact, I think they were one of the greatest organizational innovations ever created. Date back to the early 20th century. Henry Ford did not invent the automobile. He reinvented how work was organized. Instead of asking one craftsman to build an entire car, he divided work into specialized functions. One worker installed the doors, another mounted the wheels, another painted, another inspected, and specialization increased quality and productivity. It lowered costs, and the assembly line transformed manufacturing. Healthcare looked at that model and did exactly what it should have done 50 to 75 years ago. It specialized. Medicine became specialties. Specialties became subspecialties. Radiology became its own discipline. Pharmacy became its own profession. Laboratory medicine exploded in complexity. Finance became more sophisticated. Supply chain became scientific. IT, well, we know IT has become its own discipline and is very specialized. None of that was failure. That was progress. The operating model worked because healthcare itself, well, at that time was relatively linear. Patients entered through one door, received care, and left through that same door and went home. But here's the problem. Healthcare has changed. It's gotten much more complex, but that operating model largely didn't change. So today's patient is fundamentally different from the patient of 30, 40, 50 years ago. The operating model that we have built our health system on is responsible for many, many of our challenges today. So I'd like to look back to our last episode for just a moment and recap the major points. We talked about the operating model, the one that we modeled after Henry Ford's work, where we focused on specialties. We focused on facilities. Patients went in to see their doctor, or they went to the hospital and then they left. And it was fairly straightforward. And it was beautifully modeled and developed for that era. Today, with increasing complexity in our organizations, we mentioned the M&A spree that's happened in the industry the last few years. We talked about the additional systems and technologies, and we talked about the complexity of chronic disease and what we're learning about caring for those patients. And interestingly, when I first got into this industry, 60% of our cost was labor, and today it's still about 60%. The people today are the glue that makes all of this complexity work. They manage the white spaces within our organizations, across multiple organizations and across multiple sectors. And the reality, as you can see from this chart, we've got a very fragmented, reactive, complex healthcare delivery system with problems in many areas. And patients are confused, frustrated, disconnected, and left to navigate the system alone or with their family members. It creates much higher costs, poor outcomes, that frustration that I mentioned, limited accountability. People are accountable for what they do within their little piece of the system, but not for that entire patient experience or outcome. And we have a lot of burnout, a lot of waste, and a system, beds are full, appointments are scheduled months out, and it's just very, very difficult for all involved. And so, what I want to talk about will be the changes that are going to be happening over the next 5 to 10 years and what we can look forward to, what AI can bring. In fact, AI is beginning to point out some of the problems with today's healthcare operating model. But what I really want us to describe and think about are the shifts that will be happening over these next few years and how, rather than silos being a symptom of this broken operating model, how we're going to be able to work together to create something very new and reimagine that entire patient and clinician experience. So, what we're transitioning from is this siloed system that is organized around specialties, domains, or expertise, or functional responsibilities. We've got our clinical side, we've got our financial, our operational, et cetera. And the patient has to navigate their way through this complicated maze, if you will. But in the future, we're not going to be organized around silos. We're going to be organized around the patient and the outcomes and results we hope to achieve on that patient's behalf. Rather than having historic and retrospective data reviews, we'll be having data that will help in real time point out actions that can be taken on the patient's behalf. Information will converge and the system will carry the burden, not the patient or the clinicians that care for that patient. So, to give a good example of this, I want to talk about Maria, hypothetical patient. No PHI has been used here, but she's like many Medicare patients. She's 68. She lives alone. She's a retired teacher. She loves to garden, very active in her church and her community, and she loves her 3 grandchildren. She wants to stay out of the hospital. And she has right now 5 chronic conditions. And this is actually the number the average Medicare patient has. Many younger people are not on Medicare yet, have similar conditions, as well as many patients have more than the 5. But on average, the Medicare beneficiary has 5. Maria has heart failure, COPD, type 2 diabetes, chronic kidney disease, depression, and anxiety, given the life he's having to lead. And as you can imagine, she has many, many physicians. She's got 7. She's got a primary care doctor, multiple specialists, but she also has to go to multiple labs. She has imaging done. She goes to several pharmacies. She's been in the emergency department twice in the last year, home health, behavioral health. She's got a few social service agencies that work with her, several community aid agencies, community organizations, including her church, that help her out occasionally. And of course, her daughter is her primary family caregiver, but her daughter works, and sometimes it's difficult for her to get off to help Maria out. Increasingly, she's trying out virtual care just because it's convenient. But it's overwhelming. And with all of those clinicians and the 3 health systems that she's been to in the last year, she's got 5 patient portals, 12 prescriptions, and has had more than 30 appointments in the last year. And during those emergency room visits, she got hospitalized twice, and she did have 1 readmission. But every appointment begins the same way from her perspective. Tell me your medical history. What's your medication list? Who are you seeing? And in reality, she's becoming the care coordinator even though she has a case manager that she has been assigned to work with. And then there's so many waits. It can take months to get in to see certain specialists, and she's spent hours in waiting rooms, days waiting on phone calls to be returned. But you ask her what frustrates her most, and remember, she knows nothing about interoperability or governance structures that a lot of us are dealing with. She says, why do I have to tell the same story over and over? Sometimes in the same appointment, I have to tell it 2 or 3 times. Why don't my doctors seem to know what the others are doing? And why does managing my healthcare feel like a full-time job? Now, here's the important part. Every organization involved in Maria's care is doing exactly what it was designed to do. The hospital focuses on reducing that readmission that she had or eliminating it. Specialists focus on their disease and know how to optimize it. The pharmacy manages meds, home health supports recovery, payer manages costs, and they're all doing their jobs. But Maria isn't experiencing that side of it. She's looking at one continuous journey that goes across the entire health ecosystem. She doesn't really care who gets the revenue or the credit, and she doesn't wake up wondering if her cardiologist met his quality metric or if the hospital is achieving its operating margin. She's got much simpler goals. Can I stay out of the hospital? Can I breathe well enough to make it to the mailbox to pick up the mail? Can I go to church and see my friends? And can I be there for my granddaughter's birthday next month? These aren't healthcare or hospital outcomes, they're life outcomes. And that's exactly why healthcare has reached an inflection point. We've built extraordinary organizations, we've built an extraordinary health system. But now it's time to build an extraordinary experience for Maria. She doesn't happen in those silos. Her care doesn't happen in those silos. It happens across them. So let's spend some time looking at if we don't change and the trajectory for Maria over the next 8 to 10 years. It's important that we recognize all that we've done over the last 10, 15 to try to help Maria. We've built ACOs or accountable care organizations, bundle payments, Medicare shared savings programs, value-based care contracts, population health initiatives, CINs. All of these recognize that outcomes depend on multiple organizations working together, not just one. But here's the real insight. ACOs are largely a financial accountability model. They encourage collaboration, shared savings, and shared risks. But what we're talking about goes much further. We're talking about an operating model where we shift from data looking backwards, retrospective, to real time data conversion from multiple sources in multiple places, and that decisions can be made jointly across clinical, operational, and financial areas. Accountability can be shared around the patient's journey, not just through a financial contract. Coordination is built into the system itself rather than relying on those people to serve as the glue across different organizations, systems, and sectors of our industry. So I want to talk about the 6 shifts that will be happening in the next few years to change that trajectory for Maria and others like her. So the very first one is we're moving from silos to shared outcomes. Right now, most of our outcomes and our value metrics, while they are financial in nature, they are focused on very targeted outcomes. But as we've mentioned earlier, the patient journey crosses dozens of organizations, and the white spaces, both within the organizations and between the organizations, has just gotten too complex for people to be the glue that manages that work. We need a proactive, reliable system that asks questions like, is Maria on track? Where is she at risk? Who can act on that risk right now, today? And then what is the biggest impact and priority for today that in real time we can help Maria? AI doesn't eliminate the white spaces, inside our organization charts or across organizations or across the care delivery reimbursement sector. But what it will do is give us the intelligence to manage them before we have a crisis, before we get to the point that there is a problem in Maria's journey. The second shift that's going to be happening in the next few years is we're going to go from events to ongoing momentum. Today, our health system is designed to answer one question, and that's what are we waiting on, or who are we waiting on? The insurance needs to approve the care, or we've had a denial that we need to contest. Does Maria have the proper transportation, and can it get her there? Are her meds working together? And there are so many other points like that. Is the chart got the full documentation, et cetera? What's the status? We're constantly sharing information or revisiting the information we have. Tomorrow, this healthcare system is going to be about navigating, connecting, and predicting what's going to happen. And so rather than say, what are we waiting on? We're going to say, how do we act on what we already know will happen? We're going to focus on execution and not on information sharing. The value is going to shift from discovering problems to orchestrating solutions. And that's very, very exciting. We're moving in a path where we're not just going to have gobs and gobs of data like we do today. We're going to be able to converge the data and actually make proactive decisions. Maria generates hundreds of what we call signals, and that's different data sets that we can identify patterns. We can compare her to other populations or other similar patients in her situation and begin to synthesize that. Today, it's just too much. The volume is too severe for individuals or even groups of people to do it alone manually. But AI can do it quickly, rapidly, and concisely. And it can take all of the different signals and give us not a retrospective dashboard, but a forward-looking prediction of what could happen, will happen, and what interventions are necessary to prevent that from happening and certainly prevent it from becoming a crisis. So examples of the signals today, lots of clinical data, everything from labs and vitals to meds, information coming from patient-generated data and wearables. The engagement data, how is the health system interacting with her today? What appointments does she have? What appointments is she missing? What messages are going back and forth? What's her claims history so we can begin to see all of the organizations she's interacting with? What about social determinants? There's such a big correlation and they drive the preventative side of the house in a big way. So does she have the proper nutrition? What's her housing situation? Can she still drive or does she need transportation? So as I mentioned, it will focus on what should we do next and what are the priorities for Maria. Shift 4 of 6 is moving from encounters to relationships. And I want to highlight 3 different types of relationships, how they work today and how they will change over the next few years. So the very first one is that Maria and the health system, she gets involved with the health system usually when something goes wrong. She's not feeling well. She's had a crisis and needs to go to the hospital. And generally what happens today is she waits or she schedules an appointment weeks out. She waits. She tells her story multiple times in the same visit and then navigates from one provider to the next, herself or with her daughter's help. Tomorrow, the system will continuously monitor those meaningful signals. It will reach out to her proactively. It will help coordinate her care, and it will surround Maria before there's a crisis and help prevent some of the situations that are occurring today. The care team. Today, clinicians coordinate with each other through referrals, messages, meetings, case conferences, patient handoffs, et cetera, et cetera. But the information is fragmented and often delayed or sometimes non-existent. And in the future, AI is going to provide a situational awareness so that every clinician sees the same information. They can have the data that is pertinent to their specialty, but they can also see what her other specialists are doing. They'll see the same emerging risks, the same priorities, and the same opportunities for intervention in real time, not retrospectively. Another example of the relationships that will be changing is the relationship between the clinician and the patient. Much of the visit today is spent gathering information, documenting, looking back on records, coordinating logistics. But what's going to happen in the future is AI is going to synthesize all of that information, and all the routine activities will be handled. Clinicians will be able to spend important time listening, coaching, educating, and rebuilding trust. This is going to be a big change in the future. So I think the big shift is AI will constantly, in real time, pay attention 24/7, 365. It will provide Maria a digital companion that watches over her journey every step of the way. Today, nobody really pays attention to her between encounters. So that relationship will be ongoing and continuous. The other part of our healthcare system are those administrative, financial, and business leaders that have essential functions today, but they are still within their silos. And so rather than just being that siloed expert, they're going to be systems thinkers that look across a broad array of different data types and signals. And they'll still have their expertise in their own silo, but AI will help translate across the silos and make others understand the importance of factors like quality measurement, cost, staffing, capacity, and even that customer or patient experience. So the final shift that is part of what's happening is we're going to be moving from complexity to orchestration. And Maria today doesn't need another app or another portal or another alert. She needs an orchestra. AI is going to be that orchestra leader. Just like when you go to the symphony and you've got the violin and the oboe and the drums and the whatever, they still know how to play their unique instrument. But they also know how to make music together and put together a beautiful symphony with that orchestra leader. Maybe that's why I call my company Maestro Strategies. I had that systems thinking perspective. The cardiologist will still play their part, as will the nurse and the pharmacist and others. But AI will be that orchestra leader watching over her entire journey. So let's look forward. Maria will be 77 in 2035, failure and kidney disease, but she hasn't been hospitalized in 6 years. Her diabetes is in remission. Her COPD has not flared in over 2 years. She's taking fewer medications than she did a decade ago, and she's spending a lot more time gardening, going to church, and seeing her community friends. She's not sitting in nearly as many waiting rooms, and she rarely thinks about the healthcare system because it's quietly working on her behalf in the background. So, how does she view the success and the value of what has happened? Well, she attended every grandchild's birthday. She's up to 8 now. She's still independent and she's very active, even more so in her church and community. She has avoided preventable crises in her health and she's living the life she wants. And this is a much more powerful definition of value. At 68, Maria organized her life around the healthcare system. And in 2035, the healthcare system is quietly organizing itself around Maria. Thanks for joining us today. We look forward to talking a little bit more about silos in the next few weeks. We'll be having a guest or two on to talk about the changes they're seeing in their particular silo and how they're working to reimagine that patient journey across multiple organizations, entities, and healthcare sectors. Thank you.